Most of those from South Carolina will recognize Jewel as she is a certified nurse consultant and certified in infection control. She has been all over the state of South Carolina and always draws a large crowd because she is very, very knowledgeable. So, Olivia, if you would move on to our next slide, I believe Miss Jewel may be ready to join us.
Hey everybody, I'm Jewel, and because I get very distracted if I have to have my camera on, because I don't like to look at myself talk, I just like to hear myself talk. I am going to take away my camera for the time being and put it down, and we're just going to breeze through this. Thank you so much to everybody that's joining us, and a special thanks to Chris and Stephanie, and God knows Olivia, who's going to help me get through with this. The only true disclaimer that I have is that we were originally South Carolina DHEC, and on July the 1st of this year, we were separated into two agencies. We are now the Department of Public Health and the Department of Environmental Services. For those who have heard me speak in the past and know all about us and our team, I belong to a wonderful group called the HAI group, and we are the same exact people that you have always worked with. We just have a new name and a new department. So let's roll. Thank you, Olivia. Next slide. Okay, our learning objectives. Let's understand the background of it, the rationale and the intent for the development of EBPs, and why our nursing homes are going to face some challenges and how we can hopefully overcome some of those challenges. We will be talking particularly about the QSO memo that introduced the EBPs to our nursing homes and things that can help us prepare for the survey behind that. And we'll explore the implementation. How do we get them off the ground? How do we get through these challenges? And what are we seeing? And I tried to keep it as brief as I could, but I've saved a lot of time toward the end for your questions, and I want to hear those questions. Hopefully I can answer them. If not, somebody around us surely can, or we'll find you an answer. And I also want to hear what kind of success stories and what kind of challenges you have, because we can only learn from each other. Next slide, please, Olivia. Okay, for the background on this, way back in 2019, and for some of y'all, that was just yesterday, CDC released enhanced barrier precautions, as it's calling it, the best practice. And a lot of our long-term care centers went ahead and adopted this. Many did not, and were just like, and CMS did not push this at the time. They said this is good, but they did finally come around and mandate this. And most of us in long-term care know that we have to kind of go by what CMS says. Okay, on the QS memo that came out for the nursing homes on March the 30th and went live the following day on April 1st, didn't give us a lot of time to prepare for this now being a mandated thing. That QSO 2408, I think everyone has seen it, but if you have not, it will be in its detail in the resources. I have that whole thing if you want to read the whole thing. But what I take out of this for what we're doing is that basically these quotes, the facilities must align with nationally accepted standards, most of this coming from CDC. The use of enhanced barrier precautions for residents with MDROs, multi-resistant drug organisms, would be the ones with chronic wounds, indwelling catheters, or chronic, like I said, but they're still novel MDROs that come into this. And enhanced barrier precautions will be incorporated into F880 and a part of our survey. For those of us who have lived in the long-term care world, we know that in addition to F880, there will be probably citations cited under other F tags driving this up, because if you get caught on one thing, chances are they're going to find another slot to fit that into. So we want to be as prepared as we can. Next slide, please. Okay, the rationale, why they're doing this, their full intent of this is that right now, the organisms that are pan-resistant, our MDROs, or have novel mechanisms like splitting into different things or how they're doing with things, we are seeing more and more and more of these emerge. If we focus only on the residents who have an effective, active infection, and we don't focus on those who are colonized and could at some point, risk the transmission, and they can stay for long periods of times. And by those times, by the time they get really, really sick, or we see this and we need to do something, well, guess what? We've had that silent spread going on for a long time. So we do have to include those colonized people. Contact precautions, which we've all used very liberally and trust in very much, they create challenges for nursing homes too, trying to but balance their budgets, the cost of PPE, supplying costs, but they also bring us room restrictions. And of course, where does that hit you? In residents' rights and things like that. So it's a different world than when we're talking about the community, than when we're talking about a cognitive resident, or if we're talking about a non-cognitive resident, and we're talking about someone who resides in a congregate setting. Next slide, please. Okay, let's talk about what the differences are between enhanced barrier precautions and contact precautions. And this is probably one of my favorites because I've just heard people over the last, since April 1st, say to me on some of the calls, well, I'm just going to keep everybody on contact. This is just too much for us to try to figure out. Well, let's talk about why we should not do that and why enhanced barrier precautions would help us not do that. Over on one side, we have the enhanced barrier precautions. They require gown, glove only for high contact activities. They do not restrict the residents to their rooms, and they can participate in group activities. They remain in place, however, for as long as that resident is staying at your facility, or until their wound heals, or they don't have that indwelling catheter anymore, or whatever maybe put them on that list to start off with. Where in contact precautions, you have to have all dedicated equipment, which is another big expense as well. It's ideal to put them in a private room, or you have to cohort them with someone who has a like infection. They are restricted to their rooms, except for what is deemed in their care plans as medically necessitated care. It's very time limited, and I think that's one of the things that people like about that. When it's over, it's over, but are we really knowing what they're spreading? No. And it requires the gown and gloves on every entry into the residence room. So next slide, please. Okay, let's talk about what is really a definition of enhanced barrier precautions. It's a risk-based approach to using your PPE to reduce the transmission of multi-drug resistant organisms in our nursing homes. The use of gown and gloves for residents with high contact risk for colonization, and with an MDRO during those high contact resident care activities. Down the road, we'll talk about what those are listed as. Remember CMS's famous wording on everything. Examples are limited, but not limited. So just remember, you can add some things to that, and I encourage you as your facilities to do that. But, here's something, but it's not limited to the ones I listed. Use in coordination with always your core infection control, which should be your good infection and prevention measures. And it is intended for long-term use, but isolations are not required. Next slide, please. All right, in QSO 2408, at a minimum, and this is very important, at a minimum, they say that any resident colonized or infected with a novel MDRO or MDROs targeted by CDC, when contact precautions do not otherwise apply. Are you going to have people on contact for a while before they simply go to EBP? You very well could, and we'll see that as we talk about. And if I've highlighted something on here, there will be a slide that we kind of talk about what they mean by that. And or if they have wounds or indwelling medical devices, even if the resident is not known to be infected or colonized with an MDRO. So we're not simply talking about MDROs. We're talking about pathways that could lead to some of these MDROs. Next slide, please. Okay, this is what CMS as well as CDC consider high-risk contact resident activity. Now remember, you only have to go in there with that gown and glove and to take care of those high risk activities. This is why they're not locked down on total contact precautions and you have to do the full gambit. Okay, helping them dress, bathe or shower. If you're helping them transfer, maybe from bed to the wheelchair, wheelchair to the shower, whatever it may be, providing full hygiene for them, changing their linens, changing their briefs or allowing toilet and device care. Now, like I said, there can be more that you put in, and your policy and procedure can dictate this, but this is what CMS says we must do at the minimum. Next slide, please. Okay, this is a question, and I put it right here in the front because I have had this question asked of me so many times, and I know this has been a huge question asked to CDC as well as CMS. Well, what about therapy? How do they come into this play? All right, let's just talk about some basic things. Therapists should use gown and gloves when working with residents on enhanced barrier precautions when they also have prolonged activity. And it's very important to note, no one is setting a time limit on this. We didn't say 30 minutes, 2 hours. No one is saying that. CDC will not say that. CMS will not say that. They are talking about that time frame that you're there doing that activity. Make sure as you go through to develop your policies for this, you don't set a time limit, because that's one thing the surveyors do not want to see. They don't want to see a time limit on this. There is a high likelihood of transmission to those therapists close. EBP should not limit the resident's ability to participate in therapy. However, we are asking that gown and glove use be used, and while it's generally discouraged in the hallways or other common areas, it is beneficial that therapy done in the resident's room. Okay, it's kind of like when they're on isolation and therapy has to do it in the room, or they have to do it at the end of the therapy day so they can clean the gym. Remember, if that is not possible, make sure that is in that resident's care plan. Make sure that you've come up with an option that will allow them to do some of the things that may not be able to be done in their room, depending on the degree that you have to have assistance, that therapist has to assist that resident, and how long the close contact would be needed. To me, I've kind of frowned at this question when it came, because I've always considered therapy to be a part of the team that takes care of these residents, particularly, let's just say they've just got discharged from the hospital. So I don't see the big need for us to have to clarify whether therapy should do the same thing that we as, the nurses, CNAs, and everybody else does. But it has been a big, big thing that have been asked. So in your policies, again, that'll be something that you as your facility determine how you're going to make this happen with your therapy department. And you're liable to get some kickback, but this is one of the times that I say just do the right thing, because it's the right thing to do. Next slide, please. All right, other high-risk activities. This is talking about when you may have somebody who also needs to be on contact precautions, and why that's going to supersede the EBPs during that time frame, even if it's an MDRO and we need to keep them later to drop back to EBPs. This is what CDC as well as CMS says. If they have acute diarrhea, if they have a draining wound or other secretions that are not able to be covered or contained. I think of people with these large draining edematous ulcers sometime on there that no matter how many Perlex you wrap around it, it just doesn't, cover it. Are the units during an investigation or suspected confirmed MDRO outbreaks for a limited period of time? Do you have other people that you're still waiting to test? Should you be closing, should you be putting some other people on something while you're waiting to see what is? Again, your policy will dictate this. and any residents who have another infection or condition for which contact precautions are recommended. And remember that we are not trying to replace contact precautions with EBP. We are trying to offer this as a better alternative, so less restrictive for the residents. Next slide, please. Okay, what would be that novel MDRO? Okay, you've told me about these. That it either has to be a novel MDRO. You've told me that you're going to tell me what the ones are from the CDC. So, what is considered a novel MDRO? The designation of a pathogen as an MDRO for the purpose of enhanced barrier precaution is based on local epidemiology. If something is showing in your community that is not on CDC's targeted list and you choose to call that something that could affect not just one, but other of your population, that's what a novel, a new showing up something would be. Use public health prioritization. The CDC or CMS explicitly lists that, nor CMS will ever list every pathogen. I have people asking me about MRSA. I have people asking me about C. diff. If we tried to list everything, we'd be right back to where we were over on contact precautions because some of the things that go with those. So again, you have the flexibility to decide with your public health people, your medical directors, what might be a novel pathogen that's coming in to your facility. Okay, and common examples may be, and here we go with CMS, but not limited to MRSA and vancomycin resistant enterococcus. Those are the two that probably we hear about the most. Next slide, please. All right, now what are the ones we have to do, Jewel? What are the ones that the CDC has targeted that CMS is telling us we have to do? Those would be your carbapenemase producing carbapenem resistance, Enterobacterales, your carbapenemase producing resistant Pseudomonas, and y'all will see the CREs, the C SERPAs, and then one of my favorites, the crab, carbapenemase producing carbapenem resistant Acinetobacter, and then the one that we hear so much of and is really, really, really starting to turn its head coming to us in South Carolina, and I'm sure you guys have probably had it in the other states as well, which is Candida auris. So those are a must. Okay, the novels you have a little bit of leeway with, but these are the must. Okay, next slide, please. Okay, I threw this in there because I like MRSA. And in addition, I wanted to tell you that in the QSO, it says, this guidance provides facilities and jurisdiction the flexibility to implement EBPs for residents colonized or infected with additional MDROs that may be deemed epidemiologically important. I put up MRSA because you can see some of the statistics on here. Am I telling you that you need to include it? Not if you don't want to. Am I telling you you have to include it? Absolutely not. But I want us to think, once we get our basics down here, I want us to think about the population in our nursing homes. Do we have something that would say, be better for them as well as others? Then maybe we can add that. But after we get our basics covered away, know that you have a little bit of flexibility in this. If you choose to do it, by all means do. If you don't, maybe you can come back and revisit that another time. Next slide, please. What are considered a wound? Oh boy, this is another one that has really come up with questions. Initially, the mandate says in that QSO, all residents with wounds. And wounds were defined as care of any skin open that required a dressing. Boy, when I saw that, my eyebrows went up to my hairline. Because what about our skin tears? Oh my God, they happen all the time. What about a brush down on the ankle that hit that wheelchair footrest? What are they saying? Yeah, I need to put a dressing on it, but oh my goodness, what are we calling a wound? CMS has now come back and clarified this, and it's in their updated, as well as CDC's updated questions, which another thing will be on your resource slide if you need to go back and look at them. But I've put their quotations on what they say. They're referring more to chronic wounds, unhealing wounds, or wounds that are worsening. Okay? We are talking about things not a skin tear. Okay. Examples include, but there again, not limited to, your pressure ulcers, your diabetic skin ulcers, unhealed surgical wounds, chronic venous stasis ulcers, things that we all see in every nursing home is what they're targeting. They furthermore went back and clarified we are not, they didn't say concerned, but not shorter lasting wounds such as skin tears, skin breaks, and healed ostomies. Okay. This would also be another example of this would be, even though they didn't quote it in this one, a healed AV graft fistula. You know, if they're not running on that catheter, that's a healed surface. They're going to come back with that Band-Aid from their dialysis, and then it's going to come off, and that's healed per se. But let's go on to the next slide, please. I'm glad actually they came back and tried to clarify this. Same things. What are considered an indwelling medical device? Their definition: any device that provides a direct pathway for pathogens to enter the body that could potentially cause an infection. Examples include, but not limited to, central venous catheters, including hemodialysis catheters, because we all know those grafts and fistulas may give out on us at some point and they're going to run on a catheter. Okay. And PICC lines. A lot of people fussed about the PICC lines, but right now they still consider that indwelling. Okay, we're talking about urinary catheters that are indwelled. We're not talking about, you know, condom caths or things like that there. We're talking about truly inserted urinary catheters, including our suprapubic catheters, because those still have an opening. Regardless of how well they're healed, they still have that direct link to that bladder that could be that pathway. Okay, our feeding tubes, and of course, trachs, tracheostomy tubes. CMS has gone back and further clarified, again, giving us a little leeway on those questions and answers. We do not consider peripheral IVs unless it's a midline catheter. We don't consider those continuous glucose monitors that people are wearing now, or an insulin pump, nor any fully embedded device such as a pacemaker, an infusion port, or a device that no longer has communication to the outside, basically the skin, as an indication. So if you've got somebody that has a healed ostomy, if you have somebody that has a catheter, just maybe it's short term, an IV, something like that, they have clarified that. If you have any questions on what is or isn't, please use that reference given to you at the end for the questions, and make sure it's the updated one, which I have on here, where it specifically tells you what you do not have to include. Excuse me. Next slide, please. What are the challenges that we may face with our residents? And having come from the long-term care world prior to joining the Department of Public Health, I think this one probably nails it. What we have always called the 5 C's. For pretty much our community and the other people, we can, unless they're really, really, really sick, or they cannot talk to us, in general, the hospitals, even some of our long-term care acute hospitals, may not face the cognitive challenge that we face with our residents with dementia and things like that. So in an ideal world, we would have a cognitive function where they understand directions. They'd be cooperative, where they're able to follow those same directions. They'd be continent, for the most part, of urine and stool. They would be able to keep contained any secretions, excretions, or wounds. And they would have the capacity for their own cleanliness and their own personal hygiene. Well, congratulations to those who can. And I'm not trying to be flippant, but I can promise you this isn't, those that would do all those things in parentheses are not what we have in our long-term care centers. So this is one of the biggest challenges that implementing this in our facilities may cause. Next slide, please. Here's, to me, some other facility challenges. And again, this is why I want to leave us some time to talk about what you're seeing. In the post-pandemic world, people are sick and tired of not only vaccines, but they are sick and tired of having to wear PPE and having to continue to monitor it, convincing staff to take that extra step for just one little more minute. And that may be challenging. Hopefully it's not, but we all know that for the most part, we are seeing a lot of pandemic fatigue and we're wanting to see things change. Implementing routine barrier precautions, extended barrier precautions, would incur additional costs for PPE. That's one of the reasons that people say, I just can't afford it. You know, our facilities are being stretched to the limits on their budget to keep in the gowns, the gloves, put up signs, train their staff, taking that extra minute to don and doff PPE. Because remember, this is their lifetime there in your facility or until that indwelling device or whatever wound has healed or indwelling device. So we're not talking about that short term that we have for contact precautions. We're talking about for their stay. And remember, and I say this very reverently as well, this is their home. And this is where most of these people will probably stay. So we want to make sure that we're giving both them and our staff the very best care we can with the most freedom that we can allow them to have. And yes, money is a factor, but we have to find a way to make this work. Probably the most alarming would be the last one, or non-alarming for those of us who've lived in this world, staff shortages and even retention of staff. Oh, we can get some people to come in, but once they really figure out what it is, they don't necessarily want to stay. We already know without the staffing mandate, we already knew this before they came up with this wonderful idea, that we have challenges in completing quality care. They can make as many 5-star programs as they want. They can give these people the highest rating that they can, but there are always going to be those people who are going to fall through the cracks. And it is hard when you don't have very diligent people practicing the best infection control practices and taking the time and the effort to do it the right way. That's not just in our nursing homes. That could happen anywhere. But I think we see a lot more of it there. Next slide, please. Okay, how do we overcome our challenges? Well, the bottom line is we have to. We don't really have a choice. Now we're mandated. Let's talk about it. My favorite thing, do it because it's the right thing to do. If we all had that mindset, if we all practiced along the lines, we're going to do everything right, because survey could come tomorrow, and we don't want to be caught off guard. I always try to encourage my staff, let's practice like surveys in the building every day. It's a great aspiration to have. Were we able to pull it off? Of course not. But if you start it and you get it ingrained and it becomes your habitual practice, it will happen. The bottom line, we don't have a choice. We're now going to be required to do it. I do want to say that it does, even with the budget things, it could have a potential savings, because think about those people that you're keeping from getting the infections. Think about what you're saving on hospitalizations for them. We are going to be creating a safer environment for our residents, our staff, our visitors. It's going to make it better. Okay. This intervention is really a good start to trying to stop the healthcare associated infection, or our HAIs, for our facilities. We have overused so many antibiotics, and that's a whole nother thing for antibiotic stewardship. This is where we are. We have these things that we can't treat because we've run out of antibiotics to treat them. We have people still letting the family decide mama's got a cold. Well, I would like for her to have some penicillin. Okay. We have got to teach antibiotic stewardship in our facilities. We've got to embrace that as well. They could prevent subsequent outbreaks of infections or a more rigid isolation if we could keep them from getting to the fact that we had to put them on isolation and limit possibly their visitors who won't come or would come or whatever. We'll never go back to what we had when COVID came along and they say no visitors. That's never going to happen again, because we saw the mental effects of that. But if we have to start limiting things, that's not good for our residents. Remember, this is their home. And I am the very bottom line real person out of all of this. There's not a nursing home that I know. I don't care if you're one of the ones that are in the biggest, corporate group in the world. We simply cannot afford the CMPs that are going to come with this if our facility gets tagged and we have to pay that money. We are skimming by on the least we can right now, and we just can't afford to, excuse me, pay a CMP on top of everything else. Okay, next slide, please. Okay, let's talk about survey. We in our team, and for most of us in the Department of Public Health that are on this call, and thank you guys for joining us, we are not necessarily a member of the survey team. We give out a lot of guidance and advice. We work together very closely with our people in healthcare quality, but we are about guidance. We are not regulations, we are guidance. So everybody dreads to hear, in our case, Department of Public Health wants to come in and do an infection control. Okay, they think of us as all in the same. We're not. For the 8 states that have joined me, I don't know how y'all's are broken up, but for my team and for my purposes, we are not regulatory in any way, shape, or form. But I want to point out some of the things that we would be hoping, because it's written and quoted in this, that our survey teams would give a little consideration to in surveys, and hoping it would be the same way in your states. They do have some discretion while implementing enhanced barrier precautions to accommodate the need and to maintain a home-like environment for residents while still aligning with the CDC recommendations. The 3 areas that they have listed are identifying the residents for who EBPs are indicated. And with that, let me just say that if your admission nurses are not going back through that patient's history, and lots of times you don't have a lot of history to go back through because they were hospitalized for something else and now they're coming to you for rehab, now's the time to find a way to really try to dig into their past medical history. If not, you're going to have that silent spread of something that they didn't go to the hospital for, and boom, it's appeared now and you have to take care of it. How they're going to store their PPE, and how they're going to have full access to hand hygiene and enhanced alcohol-based hand sanitizer or hand rub. Those are the 3 things that we can, I won't say argue, but those are the 3 things that will give us a little leeway when survey comes in. Next slide, please. Surveyors are basically, now this is going to change, y'all. I'm going to tell you, this is what's written on the critical pathways right now for survey. Most of us, or for South Carolina, I know, and I think it would be the same way for our other states, they are still working on that module that they're going to use for F880 as well as some others. But this right now is what we are hearing and that they have been given with so far. And I promise I'll update them as more comes out. They are going to be using 3 pathways: the infection prevention and control pathway, the immunization pathway, and the care area pathway. For all of you who are familiar with critical access things, it's never going to list every little thing. Again, that's why CMS will say examples are, but are not limited to. That's their favorite writing. I still love CMS because at least they put things in red where I can tell what's changed. But, they're never going to tell you anything is all inclusive because it can't be. It never will be in life. They're going to focus right now on the CDC targeted MDROs. Okay. They're going to observe that enhanced barrier precautions used are on the required elements residents in their survey sample. For those of you who know survey, they know before they even hit the ground what percentage of who they need to see, as well as mixing some other things in there. They are going to make sure that they are not limited to, again, their survey sample is going to include, but not limited to people with enteral feeds, tube feeders, people with wounds, people who need catheter care, and people with high-risk activities. Add that to your targeted MDROs. It's pretty much brought us back to what we've said we had to do from the beginning. How they're going to do this, we really don't know. but we know that this is what their check boxes are going to look like. They're going to interview various staff. That could be your kitchen staff. That could be the person. That could be the CNA. That could be the admin. We don't know. The same way we don't ever know who they're going to come in and talk to see if they know which residents are on enhanced barrier precautions, and question if they are taking part or if they know what their interaction with that resident may be, so to see if they're a high risk contact. Okay. They're going to observe the staff and the environment to check PPE and hand sanitizer, and they're going to make sure it's readily accessible, including, I had one tell me the other day, they said, okay, if that was empty, who do you call? And that is actually written in here, who they contact to replenish it. If they being the surveyors, find that there's an inadequate supply, they're going to go to that administrator and they're going to say, what measures are you taking place to rectify this? Have you found a vendor? Tell me why you've run out of gowns. Tell me why you've run out of gloves. Tell me why you don't have this. They're going to have you want to give them an answer that you're solving your own problem. And I hope that you could get by with it. But if they find it inadequate, you may expect a tag. Okay. Next slide, please. CMS, we talked about the 3 things that they give you leeway on. This is the one for hand hygiene and alcohol-based hand rub. To perform appropriate hand hygiene, soap, water, and alcohol-based sanitizer, and a sink should be readily accessible. I think that's a part of all of us that are in the infection prevention world. We know that. It should always be in appropriate locations, included but not limited to, where do we need it right now? Most our resident care areas. However, some places cannot do this. They may not have the wall space, the area space, whatever, for whatever reason, they may have had to put a little pathway. Again, make sure it's in your policy, guys, because they're going to be looking at that to see that you recognize that. This is what they're saying. Facilities should ensure that it's readily accessible to staff. However, discretion may be used in the placement of that ADHR, which may include near or outside of the residence room. Okay. So they are knowing that there are some geographical barriers. We also know that there are those residents, the ones that I like to say, I'm just happy they're not running down the hall naked, may come up and try to get something and, ingest it. We know that for us in our world, in long-term care, there are always exceptions to any rule. So they are giving you a little consideration. Just make sure you take that consideration and work how it's best for you. Next slide, please. Okay, what are they saying for PPE storage? I kind of flipped out on this one for a moment because it's not what I consider ideal. But again, I only worked in one place. I don't know what other places and people have challenges. PPE may be stored near the residence room as long as it's readily accessible. One PPE location or one cart is acceptable for multiple rooms. Okay, when I read that, I'm like, oh boy, you're asking for trouble, but it is acceptable. While not recommended, PPE could be stored in the residence room as long as cross-contamination can be avoided. Okay, I don't know about y'all, but if I ever walked in a room and they had stuff over there in the drawer, like an isolation gown or some gloves over there, which most of us do, in at least have gloves. I'm not sure I can avoid cross-contamination, but how do I know that Miss Smith didn't get up over there and plundering in the middle of the night and do all those things to that gown that I'm about to put on? Again, I had some questions, but this will keep you legal. This will keep you in survey, so I'm keep the Jewel opinion out of this. PPE taken into a residence room cannot be used for other residents or returned to stock. I found from talking to facilities that if they go in with an over thing of things, that they're like, okay, well, I'll just put this in the drawer and use it the next time I come in this room. Okay, that's okay according to this. But are we going to cross-contaminate? And even if we're not, is somebody else going to? So just please, again, keep that in mind and make sure your policy and what you're ready to show the surveyors show that you've taken that into account. Whether that means education for your staff, you better show that you've preached this to them, that they understand what cross-contamination is, because remember, they're going to be out asking these people, you know who's on EBP and do you know why you're doing this? Okay, you just got that gown out your drawer. Did the night shift touch that? Make sure your staff is prepared. Okay. Next slide, please. And I know I sound like I'm preaching because I probably am, because I've lived this work. I'm going to apologize right now for the quality of the next few slides. For those who know that my computer has been on the fritz for about 3 months now, and we're still trying to get it worked out. So please don't judge me on the quality of what I had to do when I tried to do a screenshot or share. This is pretty much just some tools that I think would be beneficial. This is, to me, excellent signage right here. I love this one from the CDC. I think a lot of our nursing homes has adopted this as far as signage. Hey, it's on there. It's free. Print it out. Use it. That's my take on it. Most of the tools that I'm going to share can be found either on CMS or CDC, or I've gleaned them from some very reputable sources who I trust and know that they meet the recommendations. And because of these, and I could not include the whole portions of them, please, if you see something on here and you want it, reach out to me. I will get you a good, clean copy that I can email you, and you won't have to try to work from these fuzzy copies that's on my slides. Next slide, please. These are some more posters that CDC as others have made. How we keep our residents safe. I love that one. If we put that up for our visitors to see, if we put this one up, multi-drug resistant organisms are a threat to our residents, it opens the engagement for conversation about why we're even doing this, for one thing, with hopefully our visitors and family. And down on the bottom, and no matter which way I turn this, there's a part of this that's upside down. With this you'll find on CDC's, that's a little hand pocket tool for your residents and staff that can, keep it with them, whatever. Again, I'm not one that like people to have a lot of stuff in their pockets, because what are you doing? Reaching in there to say, oh, did I do this right? But these are some very, very good tools that I would encourage y'all to print off and post in your facility. Whether you choose to or not is totally up to you, but they're great. And like I said, they're just the cost of the printer ink at this point that it's going to cost you. Next slide, please. Okay, I don't even know if y'all can see these. That's why I said that please call me, text me, email me, and I will get you. This first one is an auditing checklist. It is awesome. It, you didn't do it if you didn't document it. You didn't say that you knew how your whole staff did if you didn't check it off. Do we have time to do a lot of audits? No. Again, I'm the real person in all this. I know that time is a valuable thing, but something concise like this will show you where your weak spots may be, may show you who you need to re-educate. This one actually came from the compliance store, and I like this one probably more than I liked anybody else's. So that's why that one's listed. And then over to the right-hand side of the screen is something that I think everybody should pick up. This is from CDC. You can certainly change it and apply it to your facility, but you're sending out a letter to your residents or their responsible parties explaining why you're having to do this. Okay. And there's a more detailed one. They have two. The other one goes into a lot of education about MDROs and things like that. I did not choose that one because, let's face it, they're going to read the first two paragraphs and then they're going to call you and say, what does all this mean? So I didn't give you any more things. And again, I hope that it will open conversations with your clinical staff, and as they explain it to others, the validity of it will make more sense to them as well. Not only to the visitor, but as they say it over and over, it'll make it seem real for them. And then the sample policy down there of the, it's 3 pages. The last page is kind of a summarization of kind of a little chart, if you will. This also came from the compliance store. Again, please, it is not a one and done written in stone kind of thing, but after reviewing this, it checks all the check boxes that we should for both survey as well as safety, as well as bringing in the education for all of our members of the team. One, again, that I really like a lot. Not saying that y'all have to use this, not saying you need to use it. It's just a sample, because I'm telling you, those of you who have been through survey, one of the first things you hear from somebody is, could you go get me a copy of your this policy, or may I see this? Sometimes I used to, and when I was in the facility, I loved my first hour book. I put everything in my first hour book, and I give them my first hour book and just let them entertain themselves for the infection control part of the first hour book. A lot of people don't do that. A lot of facilities don't do that. I'm not telling you have to. I'm just going to tell you it's going to save you from getting called up there to run them a copy, or God forbid you give them your original and you don't see it till the end of next year. Again, if you're lucky. So these are just some helpful hints from Julie on this. Next slide, please. Okay, this is your resource page. I would have never thought about looking on YouTube, but I'm going to tell you, that's a cute little video, and it really explains things. I'm not going to read all of these, the ones that I've kind of related to, the QSO, the frequently asked questions about enhanced barrier precautions in the nursing homes, some of the other things that are on here. As you do your own searches, as you do your own education for your staff, as use these, if you will. They've got a lot of good info. I'm one of these people that pick this out of this and this out of this, or I always hear something new in this one or whatever. So please refer to them and go from there, if you will. I think that for those of us who aren't Jewel and just don't know how to type on a page and put something up there, these videos, I know people get paid high dollars for that. I'm just plain old Jewel. I could never do that. But not only are they cute, they kind of are fascinating to me that they are able to do that. So I'm the dinosaur of the bunch. I can just read and print off and mark everything with my highlighter, and I'm a happy camper. But nowadays, that 15-minute or 10-minute video might get a lot more attention than me handing out papers to everybody. So please utilize them. They're there for you. There's tons more, but these are the ones that I think will help you the most. Next slide, please. All right, that's my picture. I want to thank you all. Again, thank you to Constellation for asking me to do this, and thank y'all for allowing me to ramble on the way that I do. That is my contact information there. And next slide, please. This is our HAI unit at DPHSC. This is the team that I am so lucky to be a part of. I always say we're the best of the best, and I will say that till I prove, or somebody proves to me that we're not, and that's going to be hard pressed, because we are the best of the best. Please reach out to us if you need us. We are always there to help. Remember, we may fall under the same silo as some people, but we're guidance, not regulatory. It's not going to hurt your facility to let us come help you. Okay, next slide, please. I think we're down to our questions, concerns, and comments. I'm ready to take myself off of, put myself back on mute, and let's hear what y'all have to say. Chris, are you ready to do this now, or do you want to finish yours and come back? What do you want to do?
Well, I tell you what, we've only got just a very few moments left before we run out of our allotted time. We don't want to take any more of your time than we've promised. And so that being said, we will come back to Joel with just a couple of minutes. And any questions that we do not get answered today, we will do our utmost to get those taken care of and get you an answer. So if you will move forward, Olivia. Okay, so a quick reference for you. HQI Academy has bite-sized on-demand learning. There is a large reference library there. There are enhanced barrier precautions, simple steps. There are sepsis things, hand hygiene, equity, diabetes prevention, those chronic disease issues that we deal with every day. These are rapidly available, short, sweet, and you get what you want. So, should you have, if you will, Olivia, should you find that you have questions where we may be able to assist you or direct you to the to resources, these are the people that you would call upon in your state. And as we've said, these slides will be shared, so you will have this information. That is the end of this, but Miss Joel, we do have a couple of questions that we're going to try to sneak in there. And so there's a question here about the utilization of alcohol swabs after drain tubage. Boy, I said that wrong. After tube drainage. And so does that come into play anywhere in this?
I don't think they got that specific. Now, y'all give me time to go back and look that up. I also know I've had people say, well, Jewel, they're not talking about using alcohol pads to wipe off things and things like that. I would love to tell you I'm going to go back and read it verbatim, but I'm going to refer back to what I always do with both CDC and CMS. They cannot cover every scenario that we have, and they're going to go by what your policy tells you that you need to do as well. And I know that's not an answer, but it's the only one I've got right now for that. I'm sorry.
Okay. One that I'm sure is a popular question. How should it be handled if a resident refuses to wear PPE? They do not want to stand out and be seen by everyone in the community as having something wrong.
Okay, first of all, it's going to be the staff that are wearing the PPE while they're doing the resident activities. Remember that resident is not going to be restricted in what they can do. Now, if they are also, active and, they may need to be on a little reform schedule, but we're talking about the people that are going to go in and have interactions with that resident. We're keeping them from transmission to us in this case, okay? Not us transmitting something to them. I hope that makes sense. We are trying to keep it, or they, when I say we, I consider myself a part of sometimes, and sometimes I say, listen, if I were truly the one writing this, it'd make a lot more common sense than this does. But you're not going to dress them up. You're not going to put them in these clothes. They're going to be free and easy to do as they need. Your staff are going to be the ones that are dressed when they're providing these high-risk contact activities.
Okie doke. So if someone has an active MDRO that is in urine and therefore can be contained, is that contact or EBP?
As long as it can be contained. Remember when we talk an active MDRO, right? And we're talking about they are urinary continent. I guess EBP if it's just for their MDRO. If the urine cannot be contained or the diarrhea or whatever, again, whatever your policy says, but they could mix with both. Pat or Allison, one of y'all from my team want to jump in on this one. I don't want to say anything that I think y'all are going to take verbatim if it's not a direct quote from, or Erin, if you're on our MDRO lead. They could be on there because they're an MDRO and they are on enhanced barrier precautions, because those 5 C's that we see so challenging, they could also need to have contact or be on contact because they cannot contain these secretions. So this would be one of those on a case by case basis is how I would take this one. But anybody else, any thoughts, or anybody on the call with any thoughts, let me know what you think on this one.
While we're thinking about that, one last question there for you. There was a question about the donning just inside the room or area door, particularly for those in a semi-private room. And there's also been discussion of the concern that residents are not comfortable with the staff donning in an area that is seen by the rest of the community because they feel it makes them feel dirty. So, do you have any words of wisdom to protect the privacy of the resident while still providing the appropriate level of isolation or emergency? Goodness gracious, I am having trouble talking today, of PPE.
I really don't. I think that's where the education to our other residents, that's why I like that letter. I would think that we are talking this up with our staff and we are able to go in and say, Miss Smith over in bed B has something, without devote the privacy. So when I come in to your room, Miss Jones and Miss Smith, you'll see that I go over and put on a gown. Is it ideal? No. Does it make that resident feel dirty or singled out? Probably. But I think with enough education and what I can only hope that that will relay some of the fears and relay some of the stuff. And for residents who have been around long enough and like their roommates, I will say there have been some really poorly chosen roommates over the time and when it all comes out. But I find that the roommates are very, very protective of their roommate. And if something has to be done, they know it's to protect that resident. They know it's to protect themselves. And usually they're the first ones to call on something like that about, you're not going to treat Miss Smith like that now if you don't have to, but if it's to keep her safe, they don't really look at it as thinking that person's dirty or whatever. But I know that that's just me talking coming from this world. But I also know that it could be considered, by some as a privacy issue or even a HIPAA type of thing. If somebody comes to see Miss Jones and they're like, oh, that's okay. Don't worry about it. She's got some bug. They need to dress like that. We don't know. We know what we say, but we don't ever know what the roommates and the visitors and other people are going to come out and say. So it's hard. It's just as hard, y'all, when they told us to, I go back to COVID again. Just as hard as they told us to make sure they could wear the mask. We don't have those people that are fully in the 5 C's. We have the people that probably are never going to be in a 5C. So I'm going to tell you that even with survey and even having spent the years that I did in long-term care, you simply do the best you can to protect everything. And yes, some things are never going to be enough for a checkbox person here or a family member there or whatever, but you simply do the best you can. Again, I know I'm giving some evasive answers, but if this was going to be easy, we wouldn't be doing it because y'all know we're the most regulated business in the world, other than the nuclear reactor facilities or our nursing homes. Or in the United States, I should say, not in the world, but in the United States. So they only give these things to those people, even what the Bible says, it don't kill us, it can only make us stronger because they're going to expect us to find a way to do it. And hopefully we will.
Well,
And
Miss
if we
Jules,
have shares of things at work, I am so excited if y'all will call and tell me what's working for your group. It may not work for another, but we have to take each other and embrace each other at this point. It's not the South Carolina nursing homes versus the Missouri. We've got to come together and be heard and see what's best for ourselves and our residents. So I am hoping that y'all will drop me a line from along and let me know what's a good thing for you guys.
Joel, we have actually run a moment over. We want to be as mindful of people's time as possible. If we have questions that have not been answered, we will certainly shoot those over to Joel and see if we can find an answer for you. We'll share links and the slides with you. And we do have a survey at the end of this that you will receive. We would certainly appreciate your feedback so that we can improve our offerings. Again, thank you for joining us and have a wonderful afternoon.